Hello, good morning. Good morning, everyone. The trailer picture abhi baki hai. So let me start. Today we are going to talk about prostate cancer, everything about it. If you have any doubts and queries, we'll speak to it later and I'll be happy to address. If you still have doubt after this live session also, you can ping me personally or log on to our hospital Facebook page or website. I'll be happy to answer all your questions. So for all of you, what is prostate? Prostate is a gland which is present only in males. It is present at the base of the urinary bladder. It's a very small gland to start with. It's not present in females actually. So till the age of 40-50 years, it's very small, around 15 to 18 grams in weight. It starts growing only after the age of 40 to 50 years. Not all the prostate enlargements are cancers. Usually it starts growing after 40 to 50 years. Majority of the glands are benign. But the cancers can arise from glands which are benign also. So we should not miss this, because treatment of prostate cancer in stage 1 and 2 gives more than 99% cure. Cure, I am talking about cure, not about prevention. Please listen to this. So what is prostate cancer? Prostate cancer is when the cells in the prostate grows without any nutrition. Example, in our body, for any cells to grow, for ourselves to grow, we need nutrition in the form of food. But cancers, they grow without any nutrition, without any blood supply. They acquire blood supply from the surrounding organs, rather from the normal prostate. So prostate cancer, the incidence is less than 5% in age of 35 years. However, as we grow old, in our literature, it reaches up to 60% in one autopsy studies when patient is around 69 years. It is the second most common cancer in men. The first being head and neck cancer. So since it's being the second most common cancer, a majority of the patients, we should have individualized screening program. So for that, in patients who are being well informed about this, in more than 50 years of age, majority of the patient, if they are well informed, they can undergo PSA screening. If you ask me what is PSA, it's a blood test which is a glycoprotein. So we take blood from the patients and subject it within 2 to 4 hours, the report shall be ready. To read this PSA report, it's very difficult for a layman. PSA, it varies with size of the gland, the infection and inflammatory status of the gland, and it can rise in cancer status also. So whenever you read a PSA report, all these things should be considered. So coming to what are the causes of this prostate cancer? Actually, there are no specific causes for this prostate cancer. If you see, there are all these causes which I tell now, those are all causal relations. That means they can be associated with this prostate cancer. First and the foremost thing which have been described in the literature is obesity, central obesity. Central obesity, when the waist circumference is more than 1 or 2 centimeter. The other causes can be diabetes mellitus. Other thing can be patient with history of smoking. Other environmental factors like cadmium can also be associated with prostate cancer. So what are the symptoms? Let's talk about the symptoms. See, many patients after the age of 50 years, they have changes in their urinary pattern. Majority of them have weak flow. They tell that, oh, I'm able to start the urination, it's taking a bit late, my flow is not that good as compared to before, I need to strain now, I was not doing this before. Even these minimal symptoms, these are all symptoms as the disease progresses locally. Even minimal symptoms like patient who was sleeping, who was having a good sleep, now he is getting up 2-3 times at night. and it is disturbing his sleep, even this increase in nocturnal frequency can be a marker of this prostate cancer. And apart from this, when in some patients it can present with blood in urine. It's called hematuria in our medical term. Some patients have blood in semen. When they ejaculate, there might be some blood smeared semen in that. And also patients who think that their erection is not becoming proper, or if they have sustained erection in some patient with metastatic disease in the sense disease has spread to the penis. In such cases, when there is erection, the erections won't come down after ejaculation. In such cases, we should always suspect, oh, there is some problem, some disease within the penis. It can be it could have spread from prostate itself. So these are all minimum symptoms that can be associated with prostate cancer. So how do we diagnose this? When you go to a clinician, urologist, uro-oncologist specifically. I am a uro-oncologist actually. I am specifically trained in uro-oncology and robotic surgery. Majority of them urologists can also diagnose. What is the difference between me and the uro-oncologist? See, I treat specifically only the cancer of this urinary tract. I have vast knowledge of this cancers of this urinary tract. So coming to the diagnosis, when you go to a doctor, uro-oncologist specifically, they usually subject you to many tests. First, they will take all the history from you. If you give proper history, doctor may proceed to other tests, clinical test. He will just examine your prostate. Doctor puts his finger in your anal canal where you do your motion. So you try to palpate the prostate. He would know how the normal prostate feels. The change in the feel of the normal prostate, may it be hardness or may it be nodularity in the prostate, it will be known to the uro-oncologist. He will suspect something. If he has strong suspicion, he will directly subject you to biopsy. If there is suspicion, I generally do serum PSA. Serum PSA, it's a blood test, a small blood test, okay? After the serum PSA, depending on the level of the serum PSA, then we subject patient to area of investigation. What investigation do we do apart from the serum PSA? See, serum PSA is a vast topic. I'll just brief to you in minimal things. Like serum PSA more than 10 nanogram per deciliter, and if there is a strong suspicion in digital rectal examination, we subject such patients for biopsy of the prostate. The serum PSA and digital rectal examination will lead us to not the confirmatory test, it leads us to diagnosis of CA prostate, but confirmation should always be done with biopsy of the prostate. How to do the biopsy? Biopsy can be done either by two ways, transrectal way or transperineal way. Nowadays, uro-oncologists or urologists are shifting. Initially, they were used to do transrectal route of prostate biopsy. Nowadays, we do transperineal biopsy. What is the advantage of doing transperineal biopsy? The infections which were associated with transrectal biopsy before, now that can be minimized with this transperineal route of biopsy. What is biopsy? We take small bits of tissues from the prostate and give it to a pathologist. Pathologist under microscope, the examination whether it's a normal prostate tissue or whether there is some difference in the cells which can be branded as cancer. So they usually give Gleason score of, if there is a cancer, Gleason score of 3+3 is the minimum they report. Patients, depending on this Gleason score, depending on the PSA and depending on the digital rectal examination, we classify patients to broadly three categories, three risk categories. One is low risk, another is intermediate risk, another is high risk. This is a broad classification. There can be other classification also. The intermediate risk can be classified as favorable intermediate risk or unfavorable, and high risk can be classified as very high risk and very high risk. So I'll just broadly classify for your understanding three risk stratification. One is low risk, one is intermediate risk, another is high risk. So what is there in low risk? Low risk, when you take Gleason will be 3+3. Nowadays pathologist doesn't give a Gleason score, they give ISUP score. What is ISUP? In 2009, this Gleason score has been modified by the Society of Uropathologists. pathologists who looks exclusively into this uropathology, they have modified this classification. They have included ISUP apart from Gleason's. So Gleason's 3+3 or ISUP 1 is included under this category. So other factors in this low risk category is PSA. PSA should be less than 10. On digital rectal examination, we give a clinical grading. Clinical grading in the sense, I see whether prostate is an organ with 2 lobes, right? So I give whether there is hardness in one lobe, whether there is hardness in both the lobes. Depending on this, we clinically classify grades. So when the cancer is hardness is limited to one lobe or less than of the one lobe, it can be classified as low risk. So next, the intermediate risk, the PSA level should be 10 to 20 and Gleason score should be 3+4 or 4+3, that is ISUP 2 or 3. And on the clinical classification, it should be T2B. T2B in the sense, the hardness is limited to more than half of one lobe. If both the lobes are involved, that is high risk, that is third stage. So when you come to the high risk, the PSA level should be more than 20 and the Gleason score should be more than or equal to 4+4 and higher. ISUP shall be more than 4, 5. So whatever Gleason score they give, like 4+4, 3+5, 5+3 or 4+5, 5+5 or 5+4, everything comes under high risk. And high risk also includes locally advanced. What is locally advanced prostate cancer? See, till now I talked about localized prostate cancer. That means cancer was limited only to the prostate. It was not grown outside the prostate. Locally advanced in the sense, the cancer has grown outside the prostate. If it's grown outside the prostate, the surrounding things will be like seminal vesicle, rectum below and bladder neck. Bladder neck in the sense, prostate is sitting in the base of the bladder, right? Whatever the attachment is there to the base of the bladder, that is bladder neck, and whatever is there below the prostate is urethra. So if it is spread to the nearby organs, it's called locally advanced prostate. Even the localized lymph nodes, if only the pelvic lymph nodes are enlarged, it is called a locally advanced prostate cancer. This is a separate entity. So first we will take apart from this, I already told, if the PSA is more than 10 and whenever there is a strong suspicion on digital rectal examination done by a uro-oncologist, then only we will subject the patient to biopsy. What if PSA is 3 to 10? Let's take it's 3 to 10. What do we do? If there is no hardness in the prostate, if PSA is 3 to 10, then we subject such patients to do MRI, MP-MRI, that is called multiparametric MRI. Usually doing multiparametric MRI in 3 Tesla is very good. It gives information very clearly when compared to 1.5 Tesla MRI. Nowadays 3 Tesla MRI are available at few centers now. So with this MP-MRI, when you subject a patient to MP-MRI, they give a grading depending on the MP-MRI. Their grading is usually PIRADS grading. They grade as PIRADS 1, 2, 3, 4 and 5. PIRADS 1 and 2, the possibility of harboring a cancer in such a lesion on MRI is very less. You mean in MRI they give some area and they tell this is a PIRADS 1 lesion, PIRADS 2 lesion. Chances of cancer presenting in that PIRADS 2 lesion is very less. So when it comes to PIRADS 3, it's doubtful. It's equivocal, what we call. Doubtful in the sense it can be either this side or that side. So when a PIRADS 3 lesion, we discuss and we counsel the patient depending on mutual discussion and mutual agreement, we can subject the patient to biopsy in PIRADS 3 lesion. But when the PIRADS goes up front after from PIRADS 3 above, like 4 and 5, the suspicion of cancer in such lesion on the MRI is high. So we need to subject such patients to biopsy. And nowadays what we do, we target such lesion also and do biopsy from other areas of the prostate also. So chances of missing cancer is very minimal. If you just do targeted biopsy, the cancer can be present in other areas of the prostate also, which would be missed on MRI. MRI can miss around 25% of the cancer, like this. So if you do both targeted biopsy and also systematic biopsy, what we call other areas of the prostate, the yield of the biopsy is high. So in such patients we do targeted and also systematic biopsy, so yield of the biopsy will be high. That's how the PSA 3 to 10 patients we deal with. PSA less than 3, we take it with a bit of pinch of salt and caution. In such patients we usually keep them on follow-up, repeat PSA if digital rectal examination is normal. There are other type of prostate cancer where PSA will be very minimal, because PSA, in such cancers PSA won't be produced by prostate cells. Those are all other types of cancer where PSA will be minimal, but whatever prostate examination done by uro-oncologist, he has a strong suspicion that cancer is present. Prostate is very hard in such patient. We subject such patients to biopsy also. Okay, because there can be other type of prostate cancer. And prostate cancer, histologically most common cancer is adenocarcinoma, what we call adenocarcinoma, acinar adenocarcinoma, because adenocarcinoma can arise from the duct also in the prostate. Most common is the acinar adenocarcinoma, that can be given as Gleason score. The other types of cancer can be, as I told, it can be ductal carcinoma in situ, it can be neuroendocrine tumor, it can be sarcomas, it can be rhabdomyosarcomas, other tumors apart from acinar adenocarcinoma. These do not produce PSA. Only acinar adenocarcinoma produces PSA. So patients who have minimal PSA also, if there is strong clinical suspicion according to the clinician or urologist and uro-oncologist, we should subject such patients to prostate biopsy. So what after prostate biopsy? You might ask. We have come to a confirmatory diagnosis of cancer is present right now. So next we need to stage the disease if there is cancer. In all cancer this is very important. Staging. How do we stage the disease? We need some investigation. In prostate, in PSA producing prostate cancers like acinar adenocarcinoma, I'll talk first PSA producing prostate cancer. So in such cases we have PSMA PET CT for staging. But in literature, if you search on the web, majority of the literature is based on CT scan and bone scan. That was a old era. Now it has been overtaken by PSMA PET CT. PSMA PET CT is required in all the patients whom cancer is diagnosed, and diagnosis is acinar adenocarcinoma. So depending on this prostate cancer, PSMA PET CT, the prostate cancer can be staged. For your information, I'll just stage the prostate. In all cancers, may it be any cancer, there will be stage 1, 2, 3 and 4. So if you take the prostate cancer, stage 1 and 2, these are the prostate cancers where cancer is limited only to the prostate. These are the stages where prostate cancer is limited only to the prostate. The cancer has not spread away from the prostate. So intervening in such patients, intervention, treating, I'll tell what are the modalities of treatment later. Treating in such patients can cure cancer in more than 95% of the patients. Remember this, please. Cancer can be cured. I'm not talking about control here. I'm talking about cure. So timely intervention is very much important in any cancer. Stage 1 and 2 cancer in prostate can be cured in 95% of the patients. And stage 3 cancer. Stage 3 cancer is that prostate cancer is spread little bit away from the prostate. Like it has spread outside, just outside the prostate, it is called capsule of the prostate, and it has spread to the seminal vesicle. This is called stage 3 cancer. So what is stage 4 cancer? Stage 4 cancer is apart from this, whatever it has spread to the surrounding organs, like as I already told, it has spread to the bladder where it's joining the prostate, it has spread to the urethra where it's joining the prostate, it has spread to the rectum, because rectum is a motion passage which is just present beneath the prostate. These are all, when the cancer is spread to all these areas, it's stage 4 cancer. Stage 4 cancer can also include, other than this, lymph nodes. I already talked, whatever cancer it is, it will always spread to the regional lymph nodes. Regional lymph node in the sense, those are very close to the organ, whatever cancer it is. So pelvis is the area where prostate is present and urinary bladder is present. So Whatever cancer is there, if it spread to the lymph nodes, it will be first pelvic lymph nodes always. These lymph nodes are like a policeman in your body. They will be enlarged in wide variety of situations. Policeman, what is the work of policeman? They stop whatever the wrongdoing is there. In body also, they stop the wrongdoings in the body. May it be infection, may it be inflammation, may it be trauma, may it be cancer. In all these cases, infection will spread to lymph node first, cancer will spread to the lymph nodes first. That's why they become swollen. So in this stage 4 cancer, the lymph nodes are also involved. And apart from that, when the regional lymph node is involved, it's called early stage 4 cancer. There are late stage 4 cancer also. Like prostate cancer usually spreads to bones. Majority of them spread to bones. So when it's spread to bones, it's called late stage 4 cancer. If it's just only the 4 bony lesions, it can be just categorized as in between early and late stage 4 cancer. Why this staging is very important? Because we need to know when we give treatment to each stage of cancer, how much percentage of it will benefit the patient. It's not about just treating the patient. We should always individualize treatment to each patient. We can treat technically anything in a word. It's not that. Doctors are also human beings. Patients are also human beings. For me, patients are God. They should get right treatment and they should be properly counseled also. So, apart from that, apart from spreading to bones, the cancer can spread to lungs, liver, anywhere in the body. These are the most common usual locations. So, once we stage the disease, this is I talked about staging for normal acinar adenocarcinoma. I already told there are other types of cancer apart from this acinar adenocarcinoma. What are those cancers? I already told, right? So those cancers won't produce PSA. PSMA PET CT is good for staging only cancers which produces PSA. So there are other investigations like FDG PET CT. For neuroendocrine differentiation, there are Dotanac PET CT. These are investigations that are used in individualized cancers. So that can also give the staging just like what I told. Always stages are same in any cancer. 1, 2, 3, 4. Whatever the cancer, whatever the investigation. So coming to next, treatment. Treatment, what we do in stage 1 and 2, I already told, it's just localized only to the prostate. It does not spread beyond the prostate. So in such patients, always we take into consideration two things, majority of the patients, like whether the patient is able to live more than 10 years of age. Patient's age is an important criteria, and what all comorbidities does he have, whatever treatment we give, whether the patient can tolerate that, sustain that. That is very important. We can't treat a 100-year person or 90-year person with whatever we know and whatever we do. It's not correct on our part. We should always individualize treatment depending on the age of the patient, whatever comorbidities, whatever diseases he already have, like diabetes, heart problem, hypertension, obesity, asthma. These are the diseases he already have. We should take into consideration such things also. And what are the treatment modalities present in high risk prostate cancer? I will first go to the high risk prostate cancer. There are two treatments for patients. One is surgery. What surgery we do for prostate cancer? It's called radical prostatectomy. What is radical prostatectomy? We remove prostate along with the surrounding tissue like seminal vesicle. We remove. This is called radical prostatectomy. So along with that, in high risk patients, we always remove pelvic lymph nodes. It's called extended pelvic lymphadenectomy. What happens if it doesn't remove? In such cases, there will be 15 to 20% of chances of microscopic metastasis in the pelvic lymph nodes, even if it's localized. So if you remove those lymph nodes, if 1 or 2 lymph nodes comes positive, that will be curative in more than 95%. Those patients doesn't require any other treatment other than this. So we should always do a lymphadenectomy in high risk cases. So in low risk cases, this I'm talking about surgery first. Apart from surgery, I'll just complete the high risk case now. Apart from surgery, there is one more option of radiation therapy. So radiation therapy can be given by many routes that radiation oncologists will be very much expertised in that field. However, I'll just give a gist of it. There can be brachytherapy, there can be external beam radiotherapy. This radiotherapy is nowadays given in different techniques like image guided radiation therapy or intensity modulated radiation therapy. And nowadays there is one option called cybernef also, which should be used very judiciously. It can't be used in all patients. If someone tells, okay, we should give cybernef to everyone, no, it should be used in only patients where it's recommended. That we know very well. So coming to they give radiation in very recently modified techniques. They give very high dose radiation to prostate itself. That they will be able to speak once we'll get a radiation oncologist sometime to talk about it. And always radiation therapy will be given in iris case with hormonal therapy. Hormone therapy is usually given for short duration or long duration. Long duration around 2 to 3 years. Short duration is given only in low risk cancer. In iris cancer, it's given for 2 to 3 years. Hormonal therapy. What is hormonal therapy in prostate cancer? I'll just brief of the hormonal therapy now itself. See, this prostate cancer requires testosterone to grow. Testosterone is produced by testes. Okay, so this testosterone is like a petrol for the engine to move. If you have a car and if you don't have petrol, you can't move the car. It's just like that. If testosterone level is got down, or if it's reduced to a level, the prostatic cancer can't grow. It will be suppressed. Sometimes if it's a minimal cancer, it will vanish also. So for this hormonal therapy, we have in different modalities like giving medicines and suppressing this testosterone. These medicines are two types: LHRH antagonist and LHRH agonist. What are these antagonists? Antagonists are given every monthly. This gets down the testosterone level to the baseline very fast. Within a week, it gets the testosterone level very to the normal level. So these LHRH antagonists are started in patients, in majority of the patients initially. Later on, in patients who does not have any comorbidities like heart issues, obesity, metabolic syndrome where obesity, hypertension, diabetes are there. In such cases, LHRH antagonists are the ones which are preferred, and these are little bit costly, and these should be given every month. Okay. So other types of hormonal injections are LHRH agonists. These agonists can be given either as a 3 monthly depot or 6 monthly depot. Every 3 months it can be given, or every 6 months it can be given. These are given in patients who does not have heart comorbidities or metabolic syndrome comorbidities. So initially, to bring down the prostate cancer into control, we usually some uro-oncologists start off with LHRH antagonists, then they convert into LHRH agonists, so that compliance will be better. Compliance in the sense patient need not come every month to the hospital to take injection. They can come once in 3 months, once in 6 months. Okay, but LHRH antagonists get the testosterone level low very fast. LHRH agonists will take around 3 to 4 weeks for the testosterone level to come back. So the action takes around 1 month to happen. So initially, if you are starting with LHRH agonist itself, we give certain tablets, because there will be something called initial flare. If you give this LHRH agonist, the testosterone level will increase in initial period. In order to reduce this testosterone level, in order to reduce this flare, we give certain tablets called AR antagonist, androgen receptor antagonist. Those are all small tablets which can be given. So these are the main hormonal agents which I discussed. So I'll go to the low risk cancer. I already discussed the iris cancer, which is limited only to the prostate. Now I'll go to the low risk cancer. Low risk cancer, if the Gleason is just 3+3, and whenever they do biopsy, they will usually take minimum this many cores, like 12 core. They have taken some small 12 bits of tissue from the prostate. In a 12 core biopsy, if Gleason score is 3+3, and if the cores are involving less than 3 cores are involved, and each core is less than 10%, each core the cancer involvement is less than 10%. In such patients, we have two options. Like in patients whose life expectancy, who does not live for, who is already old, who does not live for more than 10 years, we can just wait, which can just observe such patients. In patients who have a life expectancy more than 10 years, say they live for long. See, age is not a criteria to live for long. Always remember that even 90-year-old patient can live for another 10-15 years. So you should always think that, oh, 80 years, he is already 80 years, what's the fun treating him? No. The family history is such that the Charles's comorbidity is such that they can live for another 10-15 years in that age. You should take into consideration that thing also. So in low risk cancer, when I already told, when Gleason 3+3 is there and less than 10% of each core is positive and less than 3 cores are positive, in such patients we can just simply observe. Other thing is watchful waiting, active surveillance. What we call active